Welcome back. This is Mini Talk 2, Toxicokinetics. If Talk 1 was about why poisons are poisonous, this talk is about when and where they do their damage. Toxicokinetics describes what the body does to a toxin over time, how it's absorbed, where it goes, how it's broken down, and how it's eliminated. You've probably heard of pharmacokinetics in the context of drugs. Toxicokinetics is the same concept applied to toxins, and understanding it is what lets you predict the timeline of a toxic event, make decontamination decisions, and understand why some toxins cause delayed injury. Let's dig in. ADME is the backbone of toxicokinetics. Let's define each term. Absorption. This is how the toxin gets from the exposure site into the bloodstream. The rate and extent of absorption are critical. A toxin stuck in the GI tract can still be decontaminated. One that's already absorbed cannot. This is why the window for inducing emesis or giving activated charcoal is time sensitive. Distribution. Once in circulation, where does the toxin go? This is largely governed by its physical and chemical properties. Lipophilic toxins, fat soluble, tend to accumulate in fat, the CNS, and cell membranes. They also tend to stay in the body longer. Hydrophilic toxins stay in body water compartments and are often excreted more quickly. Protein-bound toxins in plasma are not pharmacologically active. Only free drug acts, so protein binding affects the effective concentration. Metabolism. The liver is the primary site of toxin metabolism. Phase 1 reactions, mostly cytochrome P450 enzymes, add or expose polar groups. Oxidation, reduction, hydrolysis. Phase 2 reactions then conjugate those groups to something water-soluble. Glucuronidation, sulfation, glutathione conjugation. Usually, metabolism detoxifies, but sometimes it creates reactive intermediates that are more toxic than the parent compound. This is called bioactivation, and it's central to acetaminophen toxicity. Excretion. Most toxins leave via the kidney and urine, or via the liver into bile and then feces. Volatile substances leave via the lungs. Some toxins undergo enterohepatic recirculation. They're excreted in bile, reabsorbed from the gut, go back to the liver. This cycle can significantly prolong the duration of toxicity and is why repeated doses of activated charcoal are sometimes warranted. Understanding ADME tells you when will this patient get worse and for how long. Absorption is where clinical urgency lives. Once a toxin is absorbed, your options narrow significantly. Let's look at the graph. The yellow curve shows a toxin absorbed quickly on an empty stomach. It shoots up past the toxic threshold and stays there for hours. The blue curve shows the same toxin absorbed more slowly. Food in the stomach, delayed gastric emptying. The peak is lower and later. It barely crosses the toxic threshold. This is why you'll often hear, "Did the dog eat recently?" That's a clinically relevant question with real toxicokinetic implications. First pass metabolism. When a toxin is swallowed, it's absorbed from the gut and carried to the liver via portal circulation before reaching systemic blood. The liver metabolizes some fraction right there, so the amount that makes it to the rest of the body is reduced. This is the first pass effect. For some toxins, it's substantial protection. For others, drugs that undergo extensive first pass, the dose must be higher to get the desired effect, and the margin for error narrows. Lipophilicity is a big driver of absorption. Lipophilic compounds dissolve in cell membranes and cross easily. Many organochlorine pesticides, for example, absorb avidly through skin and GI mucosa. The concept of pKa and ionization is subtle but important. Weakly acidic toxins are mostly non-ionized in acidic environments like the stomach, where they absorb well. Weakly basic toxins absorb better in the alkaline small intestine. This matters for understanding why ion trapping therapy works. We can shift body fluid pH to trap a toxin in an ionized form and prevent its reabsorption or re-entry into cells. The decontamination window, emesis, is most effective within 1 to 2 hours of ingestion. Activated charcoal works by binding toxin in the GI lumen, most effective within 2 hours, but may still help later for some toxins. After that, your priority shifts from prevention of absorption to management of absorbed toxin. Let's talk about distribution and metabolism together, because they're linked. Once a toxin is in the bloodstream, it distributes throughout the body. The volume of distribution, VD, is a concept that tells you how widely distributed a toxin is. A high VD means the toxin is leaving the blood and going into tissues or fat. This is important because toxins sequestered in fat are hard to dialyze out or removed from the body. They can also be slowly re-released over time as fat is mobilized. Protein binding is another key concept. In plasma, toxins often bind to albumin or other proteins. While bound, the toxin is pharmacologically inactive. It's not available to interact with receptors or damage cells, but it's a reservoir. If another drug or condition displaces the toxin from protein binding sites, you can get a sudden spike in free active toxin concentration. This is one mechanism behind drug-drug interactions. Now, metabolism. The liver is the metabolic powerhouse. Phase 1 reactions, primarily mediated by the cytochrome P450 enzyme family, chemically modify the toxin, usually oxidation, reduction, or hydrolysis. This often adds a polar group that makes the molecule more water-soluble and easier to excrete. Phase 2 reactions then conjugate that modified molecule to something even more water-soluble: glucuronate, sulfate, glutathione, amino acids, and the conjugate is excreted. Here's the critical concept: bioactivation. Sometimes phase 1 metabolism creates a reactive intermediate that is more toxic than the parent compound. Acetaminophen is the classic example. The liver converts a fraction of the drug to NAPQI, N-acetyl P benzoquinone amine. NAPQI is highly reactive and attacks cellular proteins and membranes. Under normal circumstances, glutathione neutralizes it, but when the dose overwhelms glutathione stores, boom, hepatocellular necrosis begins. This is why the treatment is N-acetylcysteine, which replenishes glutathione. Cats are even more vulnerable because their glucuronidation capacity is low. More acetaminophen gets shunted towards the NAPQI pathway. Excretion is the final chapter of the toxin's journey. How does the body get rid of it? The two main routes are renal and hepatobiliary. Renal excretion. The kidneys filter blood and excrete water-soluble substances in urine. This is why we convert lipophilic toxins to water-soluble metabolites in the liver first. We need them to be excretable. If a patient has renal failure, toxins and their metabolites accumulate in the body. Half-life extends, toxicity is prolonged. Biliary excretion. Larger conjugated molecules are often excreted into bile and pass into the gut. Most leave in the feces. But here's the complication. Some toxins are then deconjugated by gut bacteria and reabsorbed. enterohepatic recirculation. This is clinically significant because it means a toxin can keep circulating even after absorption is complete. This is one reason we sometimes give multiple doses of activated charcoal to interrupt this recirculation cycle by binding the toxin in the gut each time it's secreted in bile. Pulmonary excretion, important for volatile substances. This is how solvents, some anesthetics, and ethanol are partly eliminated. Half-life, T 1/2. This is the time for plasma concentration to drop by 50%. It's the clock of toxin clearance. A short half-life means rapid elimination. A long half-life means the toxin lingers and the patient needs prolonged monitoring and support. Critically, it takes approximately 5 half-lives to clear about 97% of a toxin. So for a toxin with a 12-hour half-life, you're looking at 60 hours of potential toxicity. That's the kind of information that drives admission and monitoring decisions. Urinary manipulation, ion trapping, can speed excretion of weak acids or bases by adjusting urine pH. Alkalinizing urine traps weak acids like phenobarbital or salicylates in ionized form in the tubular lumen where they can't be reabsorbed. This accelerates clearance. Now let's connect toxicokinetics to the laboratory. Understanding ADME tells you which tissues are at risk, and those are the tissues whose biomarkers you should be monitoring. Liver. The liver is the primary metabolic organ, so it's frequently a target of toxin injury or metabolite-mediated damage. ALT is the most specific marker of hepatocellular injury in dogs and cats. AST rises with hepatic and muscle damage. ALP reflects cholestasis. Bilirubin rises with hepatocellular failure or massive hemolysis. Kidney. Many toxins or their metabolites are concentrated in renal tubular cells, which have high metabolic activity and significant exposure to filtered substances. BUN and creatinine rise with glomerular filtration impairment. Urine-specific gravity gives you a sense of concentrating ability. Casts in urine indicate tubular damage. Ethylene glycol is the textbook example. It's metabolized to oxalate, which precipitates as calcium oxalate crystals in tubular cells, destroying them. Blood cells. Oxidative toxins damage red blood cells. Look for Heinz bodies, aggregates of denatured hemoglobin on a blood smear. Methemoglobin levels can be measured directly if you suspect methemoglobinemia. The blood will look chocolate brown. Glucose. Xylitol causes insulin release, hypoglycemia. Stress or corticosteroid involvement might cause hyperglycemia. Know what direction to expect. Coagulation. Anticoagulant rodenticides like brodifacoum block vitamin K dependent clotting factors. The coagulation panel, PT-PTT, will be extended well before clinical bleeding begins. Blood gas and lactate. Certain toxins cause metabolic acidosis and elevated lactate through disruption of cellular respiration. The clinical art is in the timing. A patient may look fine at presentation, but deteriorate over 12 to 48 hours as metabolites accumulate and organ function declines. Serial monitoring is essential.